Hello, welcome. My name is Dr. Anna Skold. I am the current secretary of the Medical Association of Atlanta and also a practicing palliative care doctor at the Southeast Permanente Medical Group. This webinar is geared toward educating both physicians, any provider, and also community members about elder care options. And doctors are getting so many questions as the silver tsunami hits medical practices in Atlanta and Georgia that we thought this would be a good time to stop and talk a little bit about what resources are available. For context for listeners that may not be aware of the term silver tsunami, it describes our aging population and specifically baby boomers reaching the age of 65 in a large group at this time. We will use this webinar to debunk myths and provide facts about all things elder care related, what to do when you're helping family members with diminished cognitive functional capacity, and how to plan for end of life, advanced directives and wills, and also other questions like the differences between elder care attorneys and estate planning, and so much more. We also hope to provide answers as to what primary care doctors can say to aging patients and what resources they can point them toward. I am joined today by Caroline Bufalini, Susan Ahearn, and Joanna Hurley. Caroline, could you start and please introduce yourself and your work?
Absolutely. Hello, everybody. Thank you for having me. I'm Caroline Bufalini. I'm a licensed clinical social worker. I graduated with my master's from the University of Georgia, 2011, and have been working in medical social work since 2012 in settings of acute hospitals, rehab, hospice, and for the last 6 years, palliative care with Kaiser.
That's me. Hi, everyone. I'm Susan. Hi, everyone. I'm Susan Ahearn. I'm excited to spend some time with you tonight. I am a licensed clinical social worker as well. I've been practicing since 2002. My background is hospice and palliative care, and I've been with Kaiser for the last 11 years with inpatient palliative care, geriatric clinic, regional social work, and most recently, heart failure clinic. So I'm excited to be here tonight.
I'm Joanna Hurley, and I am delighted to join you guys and feel quite honored to be included in this panel. Myself and my husband, Miles Hurley, founded Hurley Elder Care Law in the early 2000s. Our goal was to help families who were navigating a combination of long-term care issues along with trying to figure out options to actually cover the cost of long-term care. I'm an Emory University graduate and delighted again to be part of this group.
Thank you, all three of you, for joining us. I will be facilitating the conversation, and just to get us started, I'm going to send some of the questions directly to somebody, but I'd love for everybody to join in on the conversation. So Joanna, can you start by describing the difference between estate planning and elder care?
I sure can, and I think it's a great question because most of us walk around every day with a pretty good understanding of what an estate planning attorney does. They take care of things like wills and powers of attorney. Their job is to figure out what happens to your stuff when you die. That's their job. Elder law attorneys do something a little bit different. We do that. We help people figure out how to deal with their stuff when they die. But in addition, we were focused primarily on helping people who are navigating a loss of functional or cognitive capacity. And so elder law attorneys combine those two pieces together, working with people who are trying to figure out long-term care options, what's out there, how much it costs, and primarily how to pay for it. So a traditional elder law practice will combine expertise, legal expertise, but our practice actually has a holistic approach. So we actually have social workers and nurses on our staff. So when you're trying to help families navigate long-term care options, one of the most important things you've got to do is figure out where they need to be. And where they need to be often is contingent upon what they can afford. And so I know a lot of what we're going to discuss today is also going to be looking at that component. How much does this stuff cost, and how can you actually find it?
Thank you. Very helpful. And I know there aren't as many elder care attorneys as there are estate planning attorneys. How would you find an elder care attorney?
So Google is always your friend when it comes to elder law attorneys. We typically refer folks to a directory provided by the National Elder Law Foundation. And NELF, the National Elder Law Foundation, is a kind of nationwide service that licenses elder law attorneys with a very specific qualification called a CELA, a Certified Elder Law Attorney. And that's really a great place to start, because those are folks who not only specialize in elder law in their practice, but they also actually go through additional training, certification, and testing. And so, as you guys know, lots of folks can say that they're palliative care doctors, but are they really? And so this is the same thing with elder law. So we like to encourage people to look for that designation.
Yeah. Caroline, can you elaborate on the difference between an advance directive and a will?
Absolutely. I'm smiling because a lot of times we ask our patients when we see them, do you have an advance directive? And then they start to tell us all about their will. And we say, wait a minute, there is a big difference there. An advance directive is a legal document where you're going to completely identify who your medical decision makers would be in the event that you could not speak for yourself. So some folks think that this is something that is meant to wait until a time where they couldn't speak for themselves. And so we go through explaining that the best time to do it is when you are feeling very well and very clear, to designate who that person and up to 2 backups could be. There's also a place in this document to indicate treatment preferences to help be a guide to whoever your healthcare agents are. And in the state of Georgia, to make this valid, at the end, you're signing it and getting 2 witnesses. And the witnesses cannot be individuals that you have listed as a healthcare agent, family members, or members of your healthcare team. So it could be friends, neighbors, the bank teller, the customer service at the grocery store. And then the difference is going to be that a will is a legal document which allows you to designate how you want your estate and belongings distributed after your death. So the 2 big differences are, this is for while you are living, and it is for your health care. So those are the things that really help clarify it for our patients typically.
Thanks. And I agree. Most people do say, oh yeah, I have that done. And then it turns out to be their financial will that they're talking about. Susan, can you discuss the medical power of attorney, also known as a healthcare agent here in the state of Georgia, and why is it important?
Sure, I'd be glad to. So, a medical power of attorney, like Caroline was saying, is a person that you trust and appoint to be your medical decision maker. This information is part of your advance directive for healthcare, and we encourage anyone over the age of 18 to begin considering who they would trust to make medical decisions for them and to complete an advance directive for healthcare. Like Caroline was saying, it's good to have 2 backups. They don't have to be family, they can be friends, they don't have to be local. As long as we have a cell phone and a way to reach them, it will work. And I wanted to defer to Joanna from Hurley Elder Care to see if she could talk a little bit more about the financial power of attorney and how different that is from the medical power of attorney.
Thanks, Susan, and I appreciate that. They are 2 very distinct documents, and we will tell everybody who walks through the door that the most critical, important document that they put in place to plan for incapacity is actually a financial power of attorney. And that's because there just isn't a safety net option. In other parts of medical decision-making, sometimes there's a safety net option if you don't have a document in place. But for financial power of attorney, you don't have one in place, you're really stuck at the mercy of the court system. And so a general durable power of attorney for financial matters is a document that allows you to nominate somebody to make financial decisions for you if you can't make them for yourself. Now, one of the things about this document that is critical for people to understand is that it's durable. So durable means document is good through incapacity. So if you become incapacitated, the document isn't negated. And the other thing that's important to really understand is that virtually every power of attorney that's written today is immediate. And what I mean by that is that it takes effect right away. And so a lot of people think in their mind, and this is the biggest myth that we bust in our practice, there is no other myth that's bigger than this, is that a financial power of attorney can't be used until a doctor says that you're incompetent. And so if you have an immediate power of attorney, it means it's in effect immediately. Now, springing powers of attorney are the ones that require a doctor to decide that you're incompetent. And I use the analogy that a springing power of attorney is like using ether. We just don't do that anymore. And so documents that you draft today are effective immediately. So it's really important to choose somebody that you trust because they can make decisions for you right away. And so it's important to have those conversations with people to understand really how that power of attorney works. Now, I'll tell you in our experience that most people are really reluctant to use a power of attorney, even if they have one. They're afraid. They think to themselves, oh my gosh, mom's still doing okay. I don't want to take away her right to make her own decisions. And the other thing that's so important to be able to tell people is that just because you execute a document doesn't mean you abdicate decision-making for yourself. It just means that you give somebody else permission to make decisions for you if you are unable to make them for yourself. So I would highly encourage everybody to absolutely get a power of attorney in place and encourage any of your patients to do so. They can be prepared by attorneys, and the medical power of attorney, the Georgia Advanced Directive for Healthcare, is a statutory form, which means it can be made available for no cost, and it's the same for everybody.
Thank you. I think that is a big myth that people don't understand, and they don't understand how hard it is to access a loved one's funds. For example, if they're sick in the hospital for a long time and they need funds to pay for caregivers or pay the mortgage or pay to keep the utilities on, the bank is not going to let you touch it unless you have this piece of paperwork done, or you go to the court system and you pay, right, to go forward with things like guardianship and things like that.
Right.
So,
yeah, it is this kind of planning for most people, it saves money and saves time and really, again, that's why we say it's the most foundational document that you really have in place. The general durable power of attorney for financial matters. And the other thing that I neglected to say is it's really important that you have a document that allows you to do things like buy property, sell property, open accounts, close accounts. So getting support when you're preparing a document is whether it be from a tax preparer, from an attorney, just don't rely upon the attorneys from Office Depot to be able to advise you. Work with somebody, or your financial advisor, somebody who can help you understand what the document needs to be. Even your banker.
yeah.
I would chime in and say that in addition to saving time and money, it saves a lot of anxiety because it typically tends to be the worst time when you need that. You've got a loved one in the hospital and they are begging the power company to let them pay the bill.
Right.
They're already stressed. It's already a very difficult time, and that they're asking for letters, and we have to tell them this is really the document that's needed.
Well, thank you. I'm going to ask some, or maybe even make some general statements, and I'd love for people just to chime in and give some information on that topic. So one statement that I know is another big important one that tends to be a myth is medical insurance doesn't cover custodial care, and people think it does. So can we talk about that a little bit? So first, what is custodial care?
Yeah, I'd be glad to start this one. I get asked this question day in and day out about help in the home. And in the eyes of Medicare, there are two types of needs. There is a skilled nursing need and an unskilled nursing need. The skilled nursing need is what Medicare will pay for. And the easiest way to explain it to families is it's medical care that can only be given by trained medical professionals. So think of things like physical therapy, occupational therapy, wound care, and the therapists do not provide any caregiver relief. When the therapists come, they're in and out of the home in 30 minutes to an hour. What most families are needing help with is not a skilled nursing need, but the activities of daily living. And Medicare, unfortunately, considers this unskilled or custodial care. So if your families are asking for help with things like getting mom up in the morning, getting her cleaned, getting her breakfast, getting her medications, maybe sitting with her for a few hours during the day to be sure she's safe and she doesn't fall. Unfortunately, that is not paid for by Medicare. That's considered custodial care. And we usually ask families, did you take out a separate insurance policy for long-term care? Is there a way that we can piece together a team of family members, friends, neighbors, maybe even hired caregivers that can come in? But it truly takes a village to keep a person at home when they're needing help. And we are dropping two resources in the show notes. There's truly only two programs that do provide help in the home. One is a special veterans benefit for certain veterans who were enlisted during times of conflict. That's called aid and attendance. And there's also a Medicaid waiver program that provides some limited help in the home if your patient is Medicaid eligible. So that's quite a big myth that your health insurance provides help in the home. I wish it did, and I'm sure Caroline can speak to this as well.
You said it. I think I have this conversation at least one time a day. And it is unfortunate because I often am wishing I'm telling them something else. It's a strain on caregivers and it's very difficult. So we try to explore the options that are available, like the VA, Medicaid waivers, or any sort of financial ability to put that together.
Mm-hmm.
And Joanna, you had mentioned previously that you don't have to be indigent to access public health benefits. Can you talk a little bit about that, since it is very difficult to cover all of these things since insurance doesn't cover it?
And yes, and thanks for bringing that up, because public benefits, especially the Medicaid program, is there's so many, myths out there, for, again, lack of a better term. But most people, when they are thinking about Medicaid, are thinking about possibly, getting care in something like a skilled nursing facility or accessing through a Medicaid waiver program. The program was designed to make sure that people who, especially people who are married, are not indigent because of the needs of the other spouse. And so the way that the guidelines are written, if you are looking at needing long-term care at some point in your future, you can explore avenues to actually access the program without exhausting all of your resources. So most people, when they call and reach out to an elder law practice, they typically are afraid of losing their family home. That's the first thing that they're afraid of. And so we get to sort of reassure folks that, you know, property can transfer between married couples with relative ease for making Medicaid application pretty straightforward. Property can transfer to caregiver children. They've lived in a home for a period of 2 years. Property can transfer to disabled children. But the question often comes up, what happens if I'm single? Can I save my family home if I don't have anybody to transfer it to? And that's where things get a little bit dicier. And so if you are navigating long-term care for a family member, a patient, it's really wise to start thinking about whether or not public benefits need to be part of the plan. And if they need to be part of the plan, the sooner you actually get some expertise to guide you, the more options that you have. And I think one of the other things I think that's important to understand is that most of us come to public benefits through anecdotal knowledge and personal experience. So it might be a phone call that you get or that says, well, you know, my grandmother, you know, she's been in an assisted living community for 3 or 4 years now, and Medicaid pays for all of it. You forgot to tell me that she doesn't live in the state of Georgia. And so Medicaid is a state and federal partnership. And every state gets to design programs based upon their particular criteria. And so different states have different takes on things. And so in Georgia, you know, we're not a Medicaid expansion state. And so we have a more restrictive programs than other states do. And so when you're dealing with half-truths, anecdotal information, personal experience, it's really wise to kind of push all of that aside and say, hey, my patient is a Georgia resident. Medicaid is a Georgia, you know, partnership with the federal government. How does it work in Georgia? And look for support early in the game, because if you protect assets early in the game, you can access the program and hang on to most of your money. But if you are in more of a crisis mode, that's when you do much more comprehensive and expensive planning. But the biggest myth to bust today is that you have to spend all your money in order to access public benefits. You don't. And everybody needs to know that as a blanket statement, you don't have to exhaust all of your assets in order to access Medicaid benefits. We can talk later in the program about how these programs work and what kind of benefits you can get from them. But just from the standpoint of being able to access the program, you don't have to impoverish yourself in order to get benefits.
Great to know, because there are a lot of myths out there and people don't know to ask or who to ask.
Mm-hmm.
And, you know, the people on the screen are some of the people you ask, right? So social workers tend to know, elder care attorneys tend to know, palliative care team members tend to know. So depending on where you're at and what type of health care perhaps a loved one has, you could research or ask for those types of resources. Or if a loved one is in the hospital, asking for a palliative care team member to come by is a helpful way to start the conversation.
You know, I'll add this one comment. There is a tremendous amount of information on Hurley's website. I routinely
so
go
nice.
there. I go there every day. I click on links. I put them in emails and patient messages. They have one of the best booklets on explaining Who pays for long-term care? How does that work? Assisted living facility versus nursing homes. They really put a lot of resources for free on their website, and I share that every day with families. So thank you.
Well, thank you. And I appreciate you saying that because, it's interesting. Both Miles and I have our own little personal journey in the long-term care world. He
Mhm.
lost his wonderful grandfather, through kind of the all the horrible things that can happen to you when you sometimes enter the medical system. Kind of he
Mhm.
experienced that. And I lost my mom to early onset Alzheimer's, so navigated paying for care for a parent who was really young. And we had access to so many resources just simply because we were in the business. And yet we knew nothing. When you're actually standing there walking the journey, you realize how little you really know. And
Mhm.
so part of what our mission is to get as much information out there to folks, because if we
Mhm.
made bad decisions and we were lost, I can only imagine what the lay public
Yeah.
has to experience.
Yeah.
Very true. Um, so I think we should also talk a little bit about Medicare and what benefits exist under Medicare. We talked about things that don't exist under Medicare, but what does exist under Medicare?
Yeah, I'll jump in with this. I think we talked a little bit about Medicaid, and I know we hear our patients getting Medicaid and Medicare confused. They don't know which one they have sometimes. Sometimes I tell people to think of it as caring for folks as they get older, and it helps to trigger it in their mind. But Medicare is a federal health insurance program. It covers some of the cost of healthcare for people in the United States. It is for people who are over 65, but also some people under 65 may be eligible if they have a disability. There's usually, once you've become legally disabled, there's typically a 24-month waiting period before you're
Mhm.
Medicare eligible, but there are two diagnoses that jump ahead and you get it more quickly, and that's end-stage renal disease and ALS.
Mhm.
It's run by the Centers for Medicaid and Medicare Services, and those set the standards for coverage and cost. Medicare beneficiaries, they pay part of their cost through premiums. So you probably also hear Medicare Part A, B, D, and sounds like a whole
Mhm.
Medicare alphabet.
Yep.
So sometimes you see people who have A only and they don't know what that means either. So to break it down a little further, Part A is known as hospital insurance. This is going to cover inpatient hospital care, skilled nursing facilities, hospice, some home health care services, the skilled ones that Susan mentioned. Most people don't have to pay a premium for Part A because they've worked and paid their Medicare taxes for at least 40 quarters or 10 years. But there is a deductible for inpatient hospital care, co-insurance for days 61 through 90. So then you get into Medicare Part B. This is known as the medical insurance. It's going to cover going to your doctor's office visits, lab tests, medical equipment, screenings, other outpatient services. Most people do pay a premium for Part B. People with higher incomes may pay more. People who have Medicaid may have this premium waived as one of the types of Medicaid. And I'm going to skip to D, but I didn't forget C. This is the prescription insurance. Most plans charge a deductible for prescriptions and costs based on the plan, the drugs, and the pharmacy that you're using. So what I've described is your typical Medicare or standard Medicare. I think we're seeing it less and less. You used to see more. You have Medicare and you have a Medigap plan or a secondary insurance that pays what's usually about a 20% remaining cost. What we're seeing more and more are the Senior Advantage plans with Medicare. So you see the commercials on TV, you know, this Senior Advantage, that Senior Advantage. And what's happening with this is that you're going to have a commercial insurance company helping to manage both the Medicare benefit as well as what would be that secondary insurance, sort of combined together to help with that benefit. There's different versions of each of these plans, and that could be a whole day to go through Gold and Premium and, you know, which one has the higher co-pays and which one is going to be best for different folks. But there are usually at least 3 different plan options for each of the Senior Advantages. Most of these are going to include, I call them the bells and whistles. A lot of them include vision, dental plan options to tack on, as well as the prescription coverage. And then there's the other bells and whistles that you're going to see with the Senior Advantage plans. And these differ from one company to another, but you're going to see things like over-the-counter benefits. They may have a 100, 125, something like that, dollar benefit per quarter to either order through a catalog or to have a card to go into a certain type of pharmacy to order over-the-counter supplies. There may be a food card to sort of use similarly to how you would use a food stamp card to buy certain approved foods in that quarter. There may be transportation benefits. You hear about silver sneakers. This is a benefit that comes with some of these plans. And there's a handful of others. There's meal plans for folks when they get home from the hospital, some caregiver relief, usually pretty limited. What I would say is that the best advice, if you have a patient with a Senior Advantage plan, is to just make sure that they know that there's likely bells and whistles. Usually the people I talk to may know about one of them, but they didn't realize all the other things in their plan are included. So to, you know, speak with the customer service side of the insurance and just say, what are all of the benefits that come with this plan? What's the phone number? How do I access them? Is there a website? What do I do? Because I hate leaving money on the table. So most of our 65 plus hate to too.
And one question we get a lot from patients is what covers things like depends or insure or things like that. If I'm correct, some of these benefits could cover that. You could buy some depends from the over-the-counter benefit. Is that correct?
Most of them have a variety of depends, wipes. I think insure is in a lot of those catalogs as well. It's probably the catalog is gonna differ from plan to plan with which insurance, but I think there's a lot of those things.
Great
It
resource.
also depends, the food card also depends on the reason you're seeing your patient. Sometimes they have to have a qualifying diagnosis. I know for some, but not all of the patients that we see in heart failure clinic, some of them will qualify for that healthy food card and some don't. So it just kind of depends on the individual plan and the individual patient.
I think another resource that is asked about quite a bit and is difficult because we're a city full of cars is transportation resources. How do you get from point A to point B? Any good suggestions on that?
Take this one. This is the other question that I talk about all day, every day, several times a day, is help in the home and transportation. For your seniors, most of the counties that they live in will offer some type of transportation. The limitation is that they can't usually transport your patient across county lines. Some of them, like Cobb County, they've got a pretty sophisticated transportation system in place, and they can get your patient to a transfer point. But the logistics of that is not very easy. I'm not confident that I could do it, so I'm not sure that I'd be advising a lot of our seniors to do that. But a really good starting point for transportation as well as help in the home is to have your patients call Empower Line, and we have the resources, the links, and the phone numbers in the show notes, because they'll do the initial screening to see if there are any transportation resources that the county can offer. They can also help with things like MARTA mobility, which if your patient qualifies for MARTA mobility, they have to be in MARTA's service area, and it's a door-to-door service. You can bring a caregiver with you. The team at Empower Line can help explain that resource to your patients and families a little bit better, but there's part that they fill out, and then there's part that the medical provider or social worker fills out. There's also just a handful of resources that are out-of-pocket expenses. As Caroline was saying, some of the newer Medicare Senior Advantage plans do provide limited transportation, but not all of them do, or your patients might go through those round trips very quickly. So if your patient can use a cell phone, that's the big if. There are companies like Common Courtesy and GoGo Grandparent that will coordinate transportation and rides for them through Uber and Lyft. Both companies use the same Uber and Lyft drivers, but they're very different. Common Courtesy is run by Bob and Ann Carr, and they're wonderful. They pride themselves on providing micro transportation, meaning it really is planned doctor appointments Monday through Friday, 8 to 5. And then on the other side of the spectrum is a group called GoGo Grandparent, and they will work on demand. You have to set up an online account with either service, but once that's done, you can call GoGo Grandparent and have them take you to the beauty parlor, to your church, to the grocery store. They'll go buy the groceries, they'll bring you the medicines, anything you want to pay them for, they'll do that. So, and they also have a neat feature where they can text, say if you have adult children in another state, the adult children can set up the transportation, and once it's the appointment time, the driver will text the adult child in another state to say, hey, we've got mom in the car with us. She's got on a blue shirt. We're on our way to the doctor appointment. So they can give some real-time feedback as well. But you have to be able to use a cell phone for that to work.
And you have to be able to afford it.
And you have to be able to afford it. That's a good point. They charge a fare on top. They charge a fee, a service fee on top of the fare. Common Courtesy it might be as low as $5 because they're really trying to do this as a volunteer effort, coordinating the ride. GoGo Grandparent is that has all the bells and whistles, so to speak, and it's not a very economical option.
Thank you. Yes, transportation is a big issue in many places of the country, but I would say in particular in Atlanta.
I will jump in and just say it is a really useful resource if you have a cancer patient going to and from cancer treatments to reach out to the American Cancer Society. They have a Road to Recovery program. It kind of got dampened during COVID, but it's growing again, and they have a pretty large volunteer base. So if it's trips to the oncologist, to infusions, to radiation, it's worthwhile to ask them to see if there's a volunteer in that area. And a lot of times you get to stick with the same volunteer, and it becomes a very comfortable thing for them.
That is a great resource.
Thank you. So I do think I'm going to ask Joanna this one. Can you plan for long-term care costs? Can you tell us a little bit about that?
Sure. I mean, most people, let me back up a little bit. Americans, as a general rule, are very optimistic people. And even though you turn on the news and you hear a lot of doom and gloom, when it comes to our demise, most people are, relatively speaking, pretty, well, I'm going to just live to be 90 something and then I'm just going to die. And so we all want that as our end game. We all want to live vitally and wholly and then just die. But the reality is that doesn't happen. And especially for women, we all know that women live longer, and you go into any assisted living community, any skilled nursing facility, and it's like a sorority house. It's the reality of what we deal with. But if you are a planner, and if you actually start to think about long-term care as being part of your overall retirement strategy, then looking at different options to pay for care are really important. The way that most people plan to fund long-term care is to self-fund. And the reason why they're going to self-fund is because they don't think about it. Because if they actually knew how much it cost, they might plan. People buy long-term care insurance. Long-term care insurance is expensive. Most people are eligible to buy long-term care insurance usually when they're in their 50s and early 60s. About a third of the people who apply for a long-term care insurance policy are turned down. And then when they see the premium, often after 2 or 3 years, maybe even 10 years, they determine they can't afford it anymore. So long-term care insurance is not necessarily a reliable option for most people. One, because the cost of the overall policy and the actual benefit itself may not be, a part of the decision criteria to buy it. They say, well, gee, I'm not going to get a lot for it if I spend all this money. And again, we're an optimistic people. So if you're looking at a $300 or $400 a month expense for an insurance premium, you might decide to use your money elsewhere. So planning for long-term care means oftentimes planning for public benefits, planning for something like Medicaid to pay your bills, or to pay for long-term care, excuse me. And so that's typically done through, relatively speaking, pretty sophisticated legal work. And I won't get into the minutia of it here because we'd all be asleep in about 35 seconds. But what I will say is that if you decide that Medicaid may be part of your long-term care plan and or your patient's or your family's long-term care plan, then you would absolutely want to consider a trip to an elder law attorney to be able to discuss something like public benefits and how they may integrate into an overall plan for retirement and care.
From my standpoint, every once in a while, I do have a patient who has long-term care insurance, and you're very correct. People are very optimistic, and what I see is people not enacting or starting to use the long-term care insurance until it's very, very late in the game, and they don't even use very much of it. And so I always encourage people, hey, let's take that policy out and let's look at what the policy says, and let's start using it as soon as you need it and you can activate it, because people really, they don't use all of it.
Yeah, I agree. And one of the things that long-term care insurers are infamous for is making it hard sometimes to actually put in a claim. And so people maybe try and put in a claim and then they get frustrated and they just decide to push it aside. And so, if somebody is fortunate enough to have a policy, then the sooner you tap into it, the better. And we will tell you at Hurley Elder Care Law that you should pay for the care that you need today with the money that you have today. Because progressive diseases, they get worse, especially when you're dealing with cognitive impairment. It's not like people are, and I don't mean to put a damper on this, but I think we're all very clear on this. People are going to get worse. And so if you need help today, use the resources you have to pay for the care that you need today, because that will improve your overall, lifespan experience as you age.
Your family's experience as you age.
Unequivocally. Yep.
That's typically, if I find out, and I get excited when I find out someone has a long-term care insurance policy, because it's few and far between. I tell them, even if you don't need it today, you need to call and ask a zillion questions. You need to ask, are there certain caregiver groups that I am required to use? Do I have to pay in advance and then get reimbursed? How much per day does this policy cover? And is it a different amount per day if I'm getting home care versus assisted living care?
Yep.
Is there paperwork that my physician needs to fill out to qualify that I need this type of care? And you want to know those questions before you need them so that you can be ready.
All good points. How about this next question? So if you put legal documentation into place for surrogate decision making, can you still make your own decisions even with legal decisions in place?
Yes. You're always your own decision maker, no matter what. And it baffles me the number of people who call and say, well, I am my mother's power of attorney, and she says she wants to stay at home, and I don't think it's a good idea, so I'm moving her. And the reality is that you can self-determine. Georgia law is as clear as a bell that you can self-determine until such point that you cannot. And then your medical decision makers can step in and make decisions on your behalf. But remember what I said about your financial power of attorney. You can make financial decisions through, even if you don't have capacity to make them. If, we know all the stories about people who make unwise decisions as their cognitive skills diminish. But their financial power of attorney can also act. And the only way that you can remove somebody's ability to make their own decisions is to actually go into the court system and petition the court to become a guardian and or a conservator. And a guardian the guardian is the person that can decide where you live. That's effectively the power that they get. Where do you live? And a conservator is the person who figures out the dollars and cents. So they handle the financial component. But when you go into the court system, you are removing somebody's right to self-determine. They have no agency. And so it's a big deal and should be really, only a last resort. But sometimes it's the only option.
Yeah, and I think it's important to clarify, your doctor doesn't determine, Anna can speak to this, but the court is the person that sends out the evaluator. They're not coming to the doctor asking. We can complete affidavits, but I try to help family members understand, if you are pursuing guardianship or conservatorship, that's a legal process, not a medical process. And I usually give them the links for the probate court in the county where the person lives. So I know, Anna, you wanted to speak a little bit about capacity.
Yeah, so there's two terms that people get confused quite frequently, and you already kind of hit on the topic. So people talk about incompetence. Incompetence is the legal term, and as you said, that actually takes a judge and legal involvement and doesn't really have anything to do with doctors or medical teams. So I, as a physician, cannot declare somebody incompetent. It has to go through the court. Doctors can state that a patient doesn't have capacity for a decision. So medical decision-making capacity is something that can fluctuate, and it also can be different depending on the question that is being asked. And if somebody loses capacity, either short-term or long-term, that's when we use the healthcare agent, the Georgia Advanced Directive. Sometimes the healthcare agent has been called the medical power of attorney. We are trying to use the correct term that's now healthcare agent more. But if a physician says a patient doesn't have capacity, then we go and talk to the medical power of attorney or healthcare agent. And people also confuse the fact that you can have capacity for certain things, even when you have dementia. So for example, I can have a dementia patient that I speak to who can very clearly state to me that it is their daughter who takes them to their appointments, who knows their medical issues, who loves and cares for them and lives with them, and therefore they trust that daughter to be their healthcare agent. So I can have a patient with dementia create a document to designate somebody as a healthcare agent. Now, I can turn to that patient and in the same conversation ask them difficult and complex medical decisions about surgeries and treatments and things like that. And because of their dementia, they may not be able to follow what I'm saying. And so they can't make the decision about the medical question. They can tell me who I should ask, but they can't tell me the answer to the question itself. And so it's very important to be aware that incompetence and lack of capacity are two very different things, and we should try to use the right terminology. But thanks for pointing that out, because I do think it's all of us have something we get asked every single day, apparently, and this is mine.
And Dr. Skold, I will say that I have never heard an explanation as good as that. That is so spot on. So yay.
Thank you. Because I give it every day. There you go.
Well, practiced is more than practice. I think it's more than understanding. I think it was perfect.
Well, thank you.
I do too.
All right. So moving on to cost of private caregivers. So can we talk a little bit more about private caregivers? And this is for, again, we talked about non-skilled needs. So who would like to talk about that?
We can do it together. I'm sure we have this conversation many times a day. There's a range. So if you are hiring a caregiver through a private agency, you are going to usually get quoted a range per hour. I'm seeing right now right about $30 as the minimum. Sometimes you might hear 28 if you get lucky. And they'll usually tell you 28, 30, up to 50, depending on the care need. And that the 50 is really for extremely high care needs. This might be someone who is significantly overweight and lifting is more difficult, or someone who's got trach care or really complicated medical devices that require more skill. Typically, your Alzheimer's patient who needs to make sure that they're not walking out the door, someone who needs help with their activities of daily living, that's going to really be in that $30 range. Most companies do require an hour minimum, 4-hour minimum, 6-hour minimum. I'm hearing more and more now. Sometimes you can get lucky and find some companies that do not require the hour minimum, and You can stretch your money a little and have them come 1 or 2 hours in the morning and later in the day. And that's going to be what I typically see through the private duty companies. Some people know folks in the community or in their church or on care.com or on Facebook postings that provide care individually, and they tend to be a little bit less expensive. I usually tell people you got to weigh it out, because when you go through the companies, you've got folks who are licensed, who are background checked, who, if they call out sick, the agency is going to have someone that is going to fill in for them. If you are, going with the sweet lady at the church, you don't necessarily have that background check. If she calls out sick, you may not have somebody to fill in, but you may be able to make that work as a family if you have that flexibility and that the dollar savings is meaningful. All right, I'm tagging over to you, Susan.
I was just thinking, I usually tell families the same explanation. There's pros and cons to going through a home care agency versus finding a private individual. When you're going through a home care agency, it's quicker and easier to implement. They usually send a nurse out to do an assessment and then a nurse aide to actually provide the care. And they have done all the background checks and all the trainings, and they have the backup in case somebody is sick. The times that I think you can successfully get a private individual is when you've had a personal experience with it. So if a friend or a family member has been sick and they've used a person for a number of years, to me, that's the vetting and the background. But I always tell families, if you're not going through an agency, yes, the cost will come down some, but you're essentially letting a stranger in your home with your vulnerable loved one. So I would not recommend this at all if you don't have some personal connection to the individual.
Yeah. And I think it's a good idea, even when you're going through the agencies. I tell them that you need to interview and make sure that they can meet the needs, because there are the patients that all they really need is a sitter. They need to make sure that grandma's not walking down 85 after breakfast. And then there's people who have, increased really physical heavy duty care needs. You want to make sure you're not just paying someone to sit there if you really need a lot more than that. And a lot of people need help driving, and these care companies, a lot of times they can provide transportation. But of course that brings another slew of questions, was their driving record background check, all of those sorts of things. And some companies don't provide the transportation. So whatever it is that they really need, they have to interview that company to make sure they can do that. Otherwise, you're kind of back at square one.
Yeah, agreed.
I know both of you have trained me very well to suggest things like a place for mom or care patrol to go research some of these things. So we'll have those in the
Show notes.
The show notes. I like that. So we're getting close to wrapping up, and I really wanted to get back to Joanna and talking about just in general, how do we protect our elders? So what are some of the things that you're seeing? We hear about scams all the time. We hear about things that are going on with our elders that are very concerning.
It is. We get phone calls in the practice every single day about people whose family members are vulnerable to elder abuse in a variety of different ways. Financial scams are really I think the number one phone call that we're getting, and helping protect your elder patient, loved one, family member is absolutely a job for a super spy a nosy neighbor and a police officer combined into one, because it just takes so much. And so it's doing some of the most basic practical things, which may seem difficult, but right now, with the proliferation of these and the loneliness that we see in this community, the technological lack of fluency, it continues to make our elders just so vulnerable. So, most elders are the biggest perpetrators are their own family members. And that's a topic for a whole nother conversation. But for our conversation today, it's doing things like signing up for online banking to monitor financial transactions that are going in and out of your loved one's account. Putting on alerts if there are dollar amounts that are over a particular dollar sum, maybe $100, $250, something like that. Doing everything you can to keep them away from the random phone calls that they get on mobile phones. One of the things that we recommend is to make sure that, especially if you have a smartphone, to make sure that only calls from people in your contacts are actually able to come through. So blocking any outside calls other than people in your contacts in a smartphone. And so that stops the random calls, because most older folks they answer their phone because that's what they're used to doing. And even though they may not recognize the voice, they'll engage in the conversation. And that's oftentimes how the scammers start to, get their hooks in on individuals. So don't be afraid to call law enforcement when you suspect something. Don't be afraid to involve Adult Protective Services when, again, you see something that makes you really uncomfortable. And then I'll also sort of close with this. Dr. Skold did a wonderful job of talking about capacity from a medical standpoint, but financial capacity is something that can be also a moving target. People might be able to pay their bills with ease, engage in productive financial, buy and sell stocks, and yet they can be completely vulnerable to a scammer. And that's and they could give tens of thousands, hundreds of thousands of dollars away, even though they can manage their financial day-to-day life. And so recognizing that this vulnerability is out there is the best first step that family members can make. Is just because mom can pay her bills doesn't mean that she's not vulnerable to a scammer.
That's very true.
Yeah,
That's
those stories are getting sadder and sadder. People are very creative and signing people up for insurance plans, unenrolling them, all kinds of things.
Yep. And I mentioned earlier in the call about, learning so much when I walked this own journey. My own father was switched out of a long time, Medicare supplement into an Advantage plan without his knowledge.
Yeah.
And so despite the fact that, we think we know everything here because we're in the business, I couldn't stop my dad from answering the phone and somebody saying, "Oh, you want to save money?" Sure. Yeah, I want to save money.
Who doesn't?
And cha-ching, you're signed up. And so these are the kinds of things. And I think it's so critical to be able to have real conversations about agency with respect to our elders, because we all encourage people to be as autonomous as they can be. And, we all know the story of the over-involved, kids, and we all know the story of the under-involved kids. And it's trying to find that balance to be able to help people, again, maintain their autonomy, but to keep them safe.
Very important, especially as things get kind of worse and worse, in that arena. So something for all of us to pay a bit more attention to. So I just wanted to say a very big thank you to all three of you. This has been a wonderful discussion. We are going to include a very extensive list of resources in the show notes. So please be sure to check those out and share broadly. And again, would really like to thank the audience for tuning in, and Caroline, Susan, Joanna. Thank you for your time, for your expertise, for having a kind of fireside chat about elder care resources, and which is such a much needed conversation right now. And as a reminder, please stay tuned for future Medical Association of Atlanta webinars. And thank you for your time.
A pleasure.
Thank you.
Thanks for including me.